second eminent speaker in this day, Dr. Khaled Sarhan, lecturer of anesthesia in Cairo University Hospital and in our theater, otolaryngology theater. He is taking us through the recent updates through a very important topic, which is anesthesia for adenotonsillectomy. Dr. Khaled, please.
My topic is the anesthesia for adenotonsillectomy and update. And I will start my topic by this case scenario. We have a male 3-year-old patient with 17 kilograms scheduled for adenotonsillectomy for his hugely enlarged tonsils. And his mother reported snoring and sleep apnea for 1 year. Otherwise, no history of allergy or other medications. The anesthetic management for that child, the patient had no pre-medications. They started the inhalational induction, and then they rapidly secured the IV line and gave atropine 0.2 milligrams IV. Then the anesthesia was deepened by propofol 20 milligram, then intubation using a cuffed 4.5 millimeter endotracheal tube. The procedure took around 30 minutes, and the procedure went uneventfully, and the patient received about 100 cc of lactated ringer solution. Then the patient was extubated fully awake and discharged to PACU. In the immediate post-operative, the child was restless, hypoxic, and his oxygen saturation was 80% and was not responding to oxygen therapy through a nasal catheter. However, there was no stridor, wheezes, or any signs of upper respiratory obstruction. A venturi mask was applied to the patient, 60% of oxygen, and partial improvement occurs in his breathing pattern. However, his saturation remained improved to 87, but remained below 90. And a chest X-ray was ordered and showed the following. I'm not sure it's a good quality of image. However, can you see the blue dots on either side of the chest X-ray? It looks like a diffuse interstitial pulmonary edema without the heart is normal and it's not enlarged. So the patient was re-intubated after this chest X-ray, sedated and mechanically ventilated with a pressure support of 10 centimeter water, PEEP of 5, FiO2 of 0.6, and saturation gradually improved to 100%. The patient was extubated successfully after 24 hours and then discharged home later safely. Okay. I'm going to give a few seconds or a minute for the possible diagnosis. If you get an option, you can write it in the chat. Dr. Saad, you can tell me the chat differential diagnosis that is written.
I am following you, Dr. Khaled.
Okay, Dr. Jehan, you can manage.
Negative pressure, yes. Pulmonary edema.
Okay.
Negative pressure, Omnia, Lamia,
okay.
and Muhammad. The three of them, negative obstructive pulmonary edema. Yes.
Okay, I'm going to ask them how it is a negative pressure pulmonary edema without any evidence of stridor or obstruction, as we said in the diagnosis or the history of the patient. Can you imagine how this, it's a pulmonary edema, yes, but how it occurs as a negative pressure, although there was no stridor or laryngospasm or something like this in the history of the patient?
Somebody is suggesting aspiration. Second one is suggesting enlarged tonsils were removed. Sympathetic surge, obstructive sleep apnea due to acute release of chronic obstruction of upper way.
Yes.
Maybe retained mucus plug. Secondly, to chronic airway obstruction, volume overload.
Okay, this is a very good differential diagnosis, and I think almost of the listeners have the right answer, which is it might be a negative pressure pulmonary edema, or what is called a post-obstructive pulmonary edema. This is a general term rather than the negative pulmonary edema, the negative pressure pulmonary edema. Yes, it is the diagnosis of post-obstructive pulmonary edema that results due to the sudden release of the chronic obstruction, as one of the listeners have told of our colleagues have told us. And this is the answer. Yes, it's a post-obstructive pulmonary edema. We have other differential diagnoses like cardiogenic pulmonary edema. It's unlikely because the heart is normal and we have no history of cardiac troubles. Iatrogenic volume overload, yes, it might be, but the history is not consistent with this diagnosis. Aspiration pneumonia could be, but we have a bilateral shadow on both lungs. It's not typical with aspiration pneumonia. Anaphylaxis, it might be other option. And pulmonary embolism, it is not, it's a differential diagnosis of hypoxia, but not the issue in the chest X-ray. Okay, the post-obstructive pulmonary edema is a sudden onset of pulmonary edema following upper airway obstruction. We got two types of the post-obstructive pulmonary edema. We almost know the type 1 post-obstructive, which occurs due to a sudden severe episode of upper airway obstruction like laryngospasm, epiglottitis, and any cause of acute upper airway obstruction. However, the type 2, which occurs here in our case scenario, it developed after surgical relief of the chronic upper airway obstruction, like huge tonsils, as in our case, or in cases of upper airway tumors. The post-obstructive pulmonary edema incidence is low at about 1 to 1,000 in population. However, it might requires an urgent tracheal intubation in 11 to 12% of the population to relieve the upper airway obstruction. And we got risk factors for these. What is consistent with our scenario is the obesity with obstructive sleep apnea and the nasal or oral or pharyngeal surgical site, as in our patient. However, other risk factors like young male athlete, anatomically difficult intubation, short neck, and acromegaly. The diagnosis manifestation usually present immediately, but it can occur several hours later. The signs and symptoms of respiratory distress are often present, but frothy pink sputum is the hallmark sign of the post-obstructive pulmonary edema. By auscultation, it may reveal rales and occasionally wheezes from fluid compressed airway. The chest X-ray typically show a diffuse alveolar infiltrate. Fortunately, it's a benign condition, and the treatment is just supportive. With the prompt diagnosis and therapeutic action, it will resolve generally within 24 hours, as in our history. But if delayed recognition of the case, it might have a high mortality rate ranging from 10 to 14 to 40%. The treatment, as we said, is supportive, just maintaining a patent airway, adequate oxygenation via supplemental oxygen, with the addition of positive end expiratory pressure or CPAP, guided by physical examination, pulse oximetry, and arterial blood gases. The recommended initial positive end expiratory pressure level is 5 to 10 centimeters water. The use of diuretics and or steroids, which it's usually used by our colleagues in the management of such cases. However, it is controversial. Just positive pressure, positive end expiratory pressure will do the whole work. Okay, let's move to the evidence-based management of a case of adenotonsillectomy. We'll start by the indication, when to go for adenotonsillectomy. According to the American Academy of ENT and Head and Neck Surgery, we have two main indications for adenotonsillectomy, which are the recurrent throat infection and obstructive sleep disorder breathing and obstructive sleep apnea. The recurrent throat infection is defined as having at least 7 episodes of recurrent throat infection in the past year, or 5 episodes per year for the last 2 years, or 3 episodes per year for the last 3 years. And each episode should have at least one of the following, like temperature higher than 38.3 degrees centigrade, cervical adenopathy, tender lymph nodes equal or higher than 2 centimeters, tonsillar exudate, a positive test for group A beta hemolytic streptococci. and this recommendation based on a low quality of evidence. The obstructive sleep disorder breathing, the children with obstructive sleep disorder breathing and tonsillar hypertrophy, comorbid conditions like growth retardation, poor school performance, enuresis, asthma, and behavioral problems may improve after tonsillectomy. And this recommendation is based on a moderate quality of evidence. While the tonsillectomy should be offered for children with obstructive sleep apnea diagnosed by the polysomnography, and this also recommendation based on a moderate quality of evidence. This according to the guidelines released 2019 by the American Academy of ENT and Head Neck Surgery. And this is the proposed algorithm for the indication for tonsillectomy. Okay, how to evaluate the child preoperative? The first thing is the anatomic assessment of the tonsillar size, and we grade the tonsils into 5 grades from 0 grade, which is not apparent enlarged tonsils, to the grade 5, which is almost kissing tonsils, and also identification of any craniofacial or airway abnormalities. The second thing is the bleeding tendency. We have to go for a family history or past history of unusual bleeding or perusing. The preoperative cardiac evaluation is not necessary until there are known cardiac abnormalities or comorbidities of obstructive sleep apnea. Okay. What about a suspected case of obstructive sleep apnea? How we can go to handle a patient with suspected obstructive sleep apnea for adenotonsillectomy? According to the American Academy of ENT and guidelines, the clinicians should inquire whether the American Academy of Pediatrics, the clinician should inquire whether the child or the adolescent snores. First thing is you have to ask all your patients, and especially the patients going for adenotonsillectomy, about snoring. And if the answer is affirmative, or if a child or adolescent presents with signs or symptoms of obstructive sleep apnea syndrome, a more focused evaluation is warranted. And take into your consideration that the severity of the disease does not coincide with the symptoms. So the polysomnography is the gold standard for the diagnosis. Polysomnography is indicated or recommended if if the patient is less than 2 years of age, or if they exhibit any of the following, like obesity, Down syndrome, craniofacial abnormalities, neuromuscular disorders like cerebral palsy, sickle cell disease, or mucopolysaccharidosis. That is the polysomnography. As we see, it's troublesome, and so many of children with symptoms of obstructive sleep apnea could not have the polysomnography even in the developed countries. This is how we evaluate the obstructive sleep apnea using the polysomnography by the apnea hypopnea index. The apnea hypopnea index is the number of episodes of apneas or hypopneas per hour. If the episodes are 0, there is no obstructive sleep apnea. If the episodes from 1 to 5, this is a mild disease. If it is from 6 to 10, it's a moderate. If it is more than 10, it's a severe obstructive sleep apnea. And this is according to the American Academy of Pediatrics for the diagnosis of obstructive sleep apnea. If the polysomnography is not available, nocturnal oximetry could be helpful, and it's based on a low quality of evidence. This is how the nocturnal oximetry works. And this is the McGill oximetry scoring system. It scores the patient from 1 to 4 according to the number of episodes of hypoxia per time sleeping. And it can offer a good alternative to the polysomnography if the polysomnography is not present or could not be done. Okay. Let's summarize how to manage a patient with obstructive sleep apnea. First, if we have no preoperative polysomnography, we can evaluate clinically the patient If we are suspecting mild to moderate obstructive sleep apnea, and there is no comorbidities like cardiovascular involvement of the right side of the heart, like right-sided heart failure or something like that, and if the age is more than 3 years, we can manage the patient as an outpatient surgery. However, if we have comorbidities or the age is less than 3 years old, we have to admit the patient under observation for at least 23 hours in the hospital. If the clinical evaluation is suspicious for severe obstructive sleep apnea, we have to admit the patient for post-operative observation. Okay, and if we have a pre-operative polysomnography, if the apnea-hypopnea index from 1 to 10, I mean from mild to moderate, the same, and we have no present comorbidities and the age is more than 3 years old, then it's an outpatient surgery. If we have comorbidities and the age is less than 3 years, so post-operative admission for at least 24 hours. And if the apnea-hypopnea index is more than 10, this is a severe form of obstructive sleep apnea, so post-operative admission is mandatory. The second issue in the preoperative examination is the upper respiratory tract infection, which is common in the situation of adenotonsillectomy, to proceed or to delay the patient. If we have a mild upper respiratory tract infection or a severe upper respiratory tract infection, the extremes are usually the management plan is usually simple and straightforward. If it is mild, just a history of upper respiratory tract infection for more than 2 weeks, or just small rhinorrhea, mild rhinorrhea, we can proceed for surgery, whether it is with general anesthesia with face mask or endotracheal intubation. And if we have a severe form like fever more than 38, or severe sore throat, nasal mucopurulent discharge, productive cough, we usually go for postponing the patient. However, the intermediate or the midway, the moderate upper respiratory tract infection usually make it difficult to handle such patient to go for surgery or not to go for surgery. So you have to classify or stratify the risk. If the patient is less than 1 year, and if the patient had a history of recurrent attacks of asthma, and has a history of passive smoking, like his parents are smoking, if it is an ENT surgery, it is useful to postpone such patients if he is going to have a general anesthesia with endotracheal intubation, postpone for more than or equal 2 weeks. And if not, if the general anesthesia with a laryngeal mask or just a simple mask, you can go for surgery. The assessment of the respiratory risk. How can I quantify the respiratory risk of such a patient going for adenotonsillectomy? If the patient has one or more of the following criteria, he is at risk for perioperative respiratory complication. Those are the age. If the age is less than 3 years, if there is craniofacial or upper airway malformation, neuromuscular disease with pharyngeal hypotonia like cerebral palsy, signs of right-sided heart failure and elevated pulmonary artery pressure, morbid obesity, metabolic disease like mucopolysaccharidosis, respiratory disease following recent upper or lower respiratory tract infection with bronchial hyperactivity. All these patients are at risk for developing a respiratory, perioperative respiratory complication. And so the next question is to do the surgery inpatient or just ambulatory. Ambulatory tonsillectomy is feasible if the child is age is more than 3, ASA is 1, ASA class is 1 or 2, free of comorbidity liable to exacerbate the respiratory risk, and free of hemostasis abnormality. The inpatient admission is recommended if we have one or more of the following criteria. We have a clinical criteria for perioperative respiratory risk. We have hemostasis abnormality. We have respiratory difficulty on anesthesia, induction, and or recovery. Okay, to give perioperative antibiotics for such patients, or to skip giving the antibiotics. According to the American Academy of ENT Head and Neck Surgery guidelines, the clinician should not administer or prescribe perioperative antibiotics to children undergoing tonsillectomy. This is a strong recommendation based on a very high quality of evidence. This meta-analysis have done in the Cochrane Library 2010 showed that there was no evidence to support the clinically important impact of antibiotics in reducing the pain, the need for analgesia, hemorrhagic rates in cases of adenotonsillectomy. What about the perioperative investigations? Usually, we go for a complete blood picture and coagulation profile like prothrombin time, prothrombin concentration, and international normalized ratio. However, those labs are highly warranted if there is a clinical history, family or past history of easily bruising or a bleeding tendency in such patient. And they can be omitted if we have a clear history that the patient has no family history or past history of coagulation abnormalities. Echocardiography could be done if we have a patient with obstructive sleep apnea and evidence of systemic hypertension or evidence of right ventricular dysfunction like lower limb edema, congested neck veins or something, frequent and severe desaturation of less than 70%. We might have involvement of the right side with right-sided heart failure, so echocardiography is evidenced, or if the patient has a history of cardiac abnormality like Down syndrome patient. We have some goals for the anesthetic management of adenotonsillectomy. The first goal is the smooth induction of anesthesia, and the second one is protection of the airway during surgery. The third is providing a post-operative good plan for analgesia, prevention of post-operative nausea and vomiting, and smooth and rapid emergence, especially for the ambulatory adenotonsillectomy. Okay. The premedication, to use premedication or not to use a premedication. We have to weigh the risk and the benefit of giving such anxiolytics. We might exacerbate the post-operative respiratory complication, especially in the patient with significant obstructive sleep apnea. And also we have some distraction techniques that might help rather than the giving pre-medication drugs, like videos, songs, and mobile computing devices, and the parental presence during the induction of anesthesia might be better than giving the pre-medication drugs. Okay. Intravenous versus inhalational induction. This is usually a dilemma. However, if the patient are young, like less than 6 years, without a history of severe obstructive sleep apnea, inhalational induction with sevoflurane is usually done. However, older children, we may use the intravenous induction from the start using propofol. And if the child is between 6 and 12 years, the induction depends on the child's level of anxiety and the ability to tolerate the IV placement. However, if we have a children with any age and having a severe obstructive sleep apnea, and for children with multiple risk factors for perioperative respiratory adverse events, as we quantified the risk previously, the IV induction is better to be used for rapid securing the airway and prevention or decreasing the perioperative respiratory risk. The airway management, to use a cuffed or an uncuffed tube. The cuffed tube rather than the uncuffed tube is usually preferred to protect the airway from the bleeding, secretions, and from the risk of fire with the use of electrocautery. And the preformed ray tube is preferable form because it avoid the kinking when they usually use when the surgeons use the Boyle Davis mouth gag. This is a famous study, and it's one of some valuable studies about the cuffed and uncuffed tubes in children. It was published in the Anaesthesia 2018, and it found that the cuffed tubes were better than the uncuffed tubes despite in the leakage, which is quite common sense. And it was a little bit lower in the incidence of the perioperative respiratory complication in the cuffed versus the uncuffed tubes. So the cuffed tubes nowadays are the recommended one for securing the airway in the pediatrics generally, and in patients having adenotonsillectomy. Uh, okay, to use LMA, is it feasible to use LMA for adenotonsillectomy? In the matter of some centers reported the successful use of LMA in adenotonsillectomy. It provides some advantages like smooth intubation and extubation, less post-operative respiratory complication like laryngospasm. However, the disadvantage are high failure rate from 4 to 17%. They change it to endotracheal intubation, less seal, and more incidence of aspiration and inadequate exposure for the surgeon. The neuromuscular blockers. To use neuromuscular blockers or to omit a neuromuscular blockers. We have to remember that the tonsillectomy is usually a short procedure taking around 30 minutes, and the surgeons usually do not require a good muscle relaxation for the adenotonsillectomy. So avoiding the use of the neuromuscular blockers, especially for the children under the age of 10, unless a rapid sequence induction and intubation is necessary, like in cases of post-tonsillectomy bleeding. In the older children, age more than 12 or a higher body weight, a low dose of cisatracorium or rocuronium could be used to rapidly intubate the patient, or succinylcholine may be used if rapid sequence induction is needed. Remifentanil could be an alternative to the neuromuscular blockers for intubation. A higher dose of remifentanil from 3 to 4 micrograms per kilograms intravenous could be a better alternative with a very rapid recovery during the intubation of such patients. However, it's not available in here in Egypt. What about the use of succinylcholine? Succinylcholine have been used by many of the experts, even for routinely intubation of children going for adenotonsillectomy. However, this use of succinylcholine for the routine intubation in children has largely been abandoned because of the FDA black box warning on the use of succinylcholine in children. It should not be used except for emergency airway management to rapidly secure the airway. This is due to the concerns of acute rhabdomyolysis and hyperkalemia with possible cardiac arrest in children with undiagnosed muscular dystrophies. Okay, the intraoperative steroids, friend or foe. To give intraoperative steroid or not to give steroids. We have a good or a strong recommendation by the American Academy of ENT that we have to administer a single intraoperative dose of intravenous dexamethasone to children undergoing tonsillectomy. This is a strong recommendation based on a very high quality of evidence. And the doses of IV dexamethasone ranged from 0.15 to 1 milligram per kg in the literature. However, we tend to use a dose from 0.15 to zero point 0.5 milligrams per milligram per kg. The effects of intraoperative dexamethasone, it decreased the post-operative nausea and vomiting during the first 24 hours by about 80%, and it decreased the time to first oral intake and decreased the post-operative pain. However, there was a concern of increased the perioperative bleeding while using the dexamethasone. However, studies failed to get a clear evidence that it can increase the post-operative bleeding. So it is highly recommended to give an intraoperative dexamethasone for children undergoing adenotonsillectomy. To infiltrate the surgical or the tonsillar bed with local anesthesia or not. Okay, the perioperative injection or topical application of local anesthesia were not found to be effective in reducing the pain following tonsillectomy. So the 2021 prospect guidelines published this year for pain management after tonsillectomy recommends against the use of local anesthesia for tonsillectomy. What about the recovery? Recovery awake or asleep? Okay. Most patients, particularly those with obstructive sleep apnea, should be extubated awake and be able to protect their airways. And we have to do careful suctioning of the throat and nasopharynx under vision of direct laryngoscope for the fear of coroner's clot. Coroner's clot is a blood clot that develops and be hidden in the nasopharynx, especially during the airway surgeries. And it was found that it may be inhaled into the airway and cause suffocation and up to death, and hence the name of coroner's clot. After the surgery, patients must be extubated in the lateral and head down position, which is the post tonsillectomy position, and he should be maintained in this position in the post-operative period. The perioperative pain management plan. We have to use the multimodal approach for post-operative pain management after tonsillectomy, including the intraoperative administration of acetaminophen and dexamethasone, as we said before, and post-operative ibuprofen and acetaminophen around clock. The non-steroidal anti-inflammatory drugs, earlier meta-analysis showed that non-steroidals and adenotonsillectomy have an increased risk of bleeding. However, a subsequent meta-analysis published in the Cochrane again demonstrated no increase in the post-tonsillectomy bleeding except for the ketorolac intraoperative ketorolac. So it is safe to give a post-operative non-steroidal other than the ketorolac like ibuprofen or other options. And opioids should be reserved as a rescue analgesia only, especially if the patient having obstructive sleep apnea syndrome. This is a good protocol by the Cincinnati Children's Hospital. They adopted this protocol for perioperative pain management. They give around the clock acetaminophen for a maximum of 75 milligrams per kilograms per day, dexamethasone once per day for 3 days, ibuprofen as needed, and they begin ibuprofen from the day 2 and limited to 2 doses per day only. I'm going to focus on that horrible post-operative complication, which is the post-tonsillectomy hemorrhage in brief slides. The post-tonsillectomy bleeding is an infrequent, potentially life-threatening complication of the tonsillectomy. Bleeding may occur in the first 24 hours, hemorrhage, or may be delayed, most commonly occurring from 5 to 12 days after surgery, which is called secondary hemorrhage. Our concerns for a patient coming for post-tonsillectomy hemorrhage are the hypovolemia, because much of the blood can be swallowed and vomited blood may be difficult to estimate. So the hypovolemia may be evident, and the amount of the blood can be a very small amount in his mouth. The second thing is the full stomach, because most blood is swallowed and it make the patient at risk of aspiration. The third issue is difficult intubation, even if the patient was easy to intubate in the first time, especially if it occurs in the first 24 hours. This due to tissue swelling and the blood in the oropharynx. So the strategy, we have to be prepared for the difficult airway management by different cuffed endotracheal tubes, various sizes, suction apparatus, cross-matched packed RBCs, we have to insert two wide bore cannulae and start the IV fluid resuscitation before induction for the fear of hypotension with induction. Rapid sequence induction with either low dose of propofol or ketamine or even etomidate, and followed by placement of the cuffed endotracheal tube is the best way to secure the airway, and the emergence should be fully awake. Thank you so much.
Here is another excellent presenter and excellent presentation. I thank you very much, Dr. Khaled Sarhan, for your very informative and up-to-date presentation about managing and anesthesia for adenotonsillectomy. That were really the recent updates. You went through assessment of the patient with polysomnography, clinical evaluation according to comorbidities, presence of comorbidities or not, age, apnea, index. You took us through the procedure. Will it be done according to ambulatory rules, or the patient should be admitted, and the presence of perioperative respiratory complications. Thank you for elaborating that no use of antibiotics. Antibiotics are not needed neither before surgery or during surgery for adenotonsillectomy procedure. Investigations varying from no investigations needed to the CBC and prothrombin concentration, INR. You took us again through the induction, either inhalational or intravenous, and the factors governing the pattern of induction, age and anxiety, and you specified that in severe obstructive sleep apnea, intravenous route is better with better prognosis according to the respiratory complications. We went through the airway management, cuffed or uncuffed the tube, and of course cuff the tube to minimize the leakage and to minimize respiratory complications. Could adenotonsillectomy be done with LMA, laryngeal mask airway, and a problem with a failure rate approaching 17%. Steroids, and this is really update, and the single intravenous dose of dexamethasone to be given for the adenotonsillectomy. The recovery, awake or asleep. Of course, it's awake and awake and awake, and the suction under vision, and the very important item, pain management, acetaminophen, dexamethasone, and ibuprofen if needed. And a very important topic and life-threatening topic that we all at the otolaryngology theater have our fears from it, having a patient with post-tonsillectomy hemorrhage with hypovolemia, full stomach, difficult intubation, and how to manage such a patient. Thank you very much once again, Dr. Khaled. Let me take.
Thank you, Dr. Jehan. I have a question. Do we have the questions before?
Yes,
I'm
going to take. Yes, please. I'm going to take 5 minutes for both presentations, Dr. Ahmed and Dr. Khaled. Let's start by first questions. I have them here. Yes, to Dr. Ahmed. What about patient with emergency pregnancy, and after IV induction, you discovered that she has difficult intubation? Pregnant female, while doing emergency cesarean section, and after intravenous induction, you discovered that she's difficult intubation. Dr. Ahmed Fatouh.
Yes, Dr. Jehan, I have answered this question in a written way, but we can say that the main issue here is for oxygenation, not intubation. Many operators all the time think about how to intubate the patient. Here we have to maintain oxygenation of the patient to save the mother's life and the baby life. So according to the algorithm we showed, if the patient can be ventilated with face mask, so we can maintain oxygenation through this way. then we can try using some helping tools like using of bougie, stylet. We can reposition the patient rampant position or any other position according to the situation, taking in consideration that pregnant females should be considered with difficult airway all the time. Here, if the patient can be ventilated, but of course, the bad scenario for if can't be intubated, can't be ventilated. So we can try with some rescue devices like supraglottic airway device, hoping to succeed in ventilating the patient. Either we have another option that front of neck access airway.
Maybe Dr. Ahmed, I'd like to repeat your salient point of view at the lecture that call for help. Remember to call for help. It's,
yes.
It's a nightmare having a full stomach, a pregnant lady with difficult intubation. So remember to call for help. Oxygenation is perfect, is actually our target, is to ventilate, to oxygenate, and to take carbon dioxide out. If you can ventilate, remember that having a fiber optic at this situation would really be very helpful. Getting an expert in fiber optic intubation might solve the problem. Otherwise, you are confronted with, as you mentioned, Dr. Ahmed, CVCI, cannot ventilate, cannot intubate, go for surgical airway. And yani, God bless you, it's a real difficult situation. Next question, Dr. Ahmed. Why do you use term non-invasive for fiber optic intubation, although it is considered invasive maneuver, and term invasive with tracheostomy, although we can call it surgical airway? It is something about the terminology. Please, Dr. Ahmed.
This terminology, it's not my terminology. This is the terminology of ASA algorithm. If we took a look, we will find that their terminology. But I think these terms and titles will not take away from the main issue, which is how can we deal with the difficult airway. This terminology, it returns to the ASA algorithm, not mine. I think that it will not take away far from our main purpose of the lecture.
Yes, it both works. Yani, I think, thank you, Dr. Ahmed, very much. Another question, can we use LMA after fiber optic safely? Actually, I'm not getting the point. Did you? Can we use LMA
yes.
after fiber optic?
I think Dr. Jehan, she asked if I tried to use fiber optic intubation and I failed. Can I use laryngeal mask airway to save the patient? I think this is a question.
I thought, can we use fiber optic through LMA? Maybe. I'm not sure. Yani, give me your answer, please, Dr. Ahmed.
I understood this question that we can use fiber optic, we can use the laryngeal mask airway after usage of fiber optic intubation. I think that if this is the question, if the airway not complicated after usage of fiber optic intubation, like the patient experienced laryngospasm or bronchospasm, so we can use it. Or if the patient from the start did not has any difficulties with supraglottic airway device, of course it's considered one of the greatest tools for rescue devices in this situation. So we can use it. It's no problem. I think so.
Okay, and here is another question, Dr. Ahmed. Thanks, Dr. Ahmed. But if the patient is not fasting or just eat, and I cannot intubate, yani that's full stomach patient. What about aspiration, as it will happen by fundal pressure or manipulation?
This question, Dr. Jehan, is an extended one for the first question, which talks about the pregnant woman. And you said, and we said that this situation becomes or turned into can't intubate, can't ventilate scenario. In this situation, call for help, as you greatly said, and we can think about front of neck access or maintaining oxygenation by any means.
Okay, why midazolam, either nasal or oral, is not being used for kids as good anxiolytic prior to induction by 20 minutes? I guess this is for Dr. Khaled.
This is for
yes, Dr. Khaled.
As I mentioned, yes, we can use the anxiolytics. However, if we are confronted with a child with obstructive sleep apnea or at risk of obstructive sleep apnea, we can omit the use of the midazolam or any anxiolytics because we have another alternatives. Just you can have the parents of the child immediately during the induction of anesthesia. You can have a good anti-anxiety without giving any medication. However, you can use intranasal or intramuscular midazolam or any of the anxiolytic if you are suspecting, if you are not suspecting that the patient is at risk of perioperative respiratory complication.
Thank you very much, Dr. Khaled. Another question: is there a rule for CPAP management for patients with severe obstructive sleep apnea preoperatively?
Yes, there is a rule if the patient is already on a CPAP treatment, on a home CPAP treatment. But if the patient is not at home CPAP treatment, the value is questioned. These results are for adults, and it is not. It can be given as a clue for the management of the children as well.
Thank you. Any place for laryngeal block, superior laryngeal nerve block, and recurrent laryngeal nerve block in managing awake intubation of the difficult airway? I think this is back to Dr. Ahmed Fattouh.
Of course, block of the superior laryngeal nerve considered one of the means of anesthetizing the airway before dealing with it in the awake patient. Either we can use spray as you go technique using lidocaine, or we can make superior laryngeal nerve block. I think it's okay.
Thank you, Dr. Ahmed. Which is better, nasotracheal or orotracheal intubation for tonsillectomy? Dr. Khaled, please.
Okay, the old school is the nasotracheal intubation. However, the modern practice nowadays is the oral intubation, the central oral intubation, and fixing the endotracheal tube to the lower mandible. This give a good chance for adenoidectomy and tonsillectomy as well, and also for the surgeon. If we used a preformed ray tube or something, it would be better, and the kinking of the tube might not occur. And even if we used the classic endotracheal tube, if we used the appropriate size of the mouth gag, it will not happen to occur. The kinking of the tube will not occur.
Thank you very much. And about control of bleeding by tranexamic acid, or is it beneficial? Is it beneficial to use tranexamic acid to control probably they mean post-tonsillectomy bleeding?
If the question is about the post-tonsillectomy, yes. In every bleeding patient, the tranexamic acid, especially in the early few hours, is very beneficial in controlling or decreasing the bleeding post-operative. Yes. However, giving it as a routine during tonsillectomy is not mentioned. I haven't read about it.
Thank you, Dr. Khaled. when can we give muscle relaxant when encountering difficult intubation to ensure adequate muscle relaxation? In which conditions? Yani, what are the conditions that we can give muscle relaxant despite we are encountering difficult intubation to facilitate intubation and to ensure adequate muscle relaxation?
In our classic practice with patients with difficult airway, we start with inhalational induction or IV induction with propofol or fentanyl without giving a muscle relaxant.
Yes.
Then, after the patients become deeply asleep, we can take a look about the airway. If you felt that the airway may be, you may it's bending possibly to be intubated, so you may give neuromuscular blockers, then intubate the patient. So you can make this decision after the patient going into deep sleep, either with inhalational anesthesia or IV anesthesia. You can take a look on the airway through direct or direct laryngoscope. If you felt that the airway can be easy to you, you can then give muscle relaxation and intubate the patient.
Thank you, Dr. Ahmed. And sometimes actually we add something from our experience that we try to ventilate the patient with inhalation or with IV without giving muscle relaxant and see for the chest rise, if it is adequately rising, we might proceed to muscle relaxant. Thank you very much. Regarding aspirating the blood from the stomach by nasogastric tube for a case of post-tonsillectomy hemorrhage, what is the best timing to do this? Should it be before or after induction? Dr. Khaled?
Yes, it should be after induction of general anesthesia, because even if you emptied his stomach, or even if the patient has vomited the blood from his stomach, you have to manage the patient as if he is a full stomach, and you have to rapidly secure using the rapidly secure his airway using the rapid sequence induction. So it is I mean, you can go for rapid sequence induction, and then you can manage to do nasogastric tube and deflate his stomach.
Thank you very much. Accepted INR level to do adenotonsillectomy as a preoperative preparation. INR.
Less than 1.5.
What about clonidine for postoperative kids after tonsillectomy?
Yes, clonidine has not been mentioned in the literature. However, dexmedetomidine is a good alternative, and we have many papers about the use of the clonidine in the management